Multinodular goiter describes a nodular enlargement of the thyroid gland. The gland function may meet the demands of target organs, a state called euthyroidism, or function may exceed the normal physiologic requirements of the body, a state called hyperthyroidism. Most commonly, multinodular goiter occurs as a consequence of iodine deficiency, which in some regions of the world may be endemic. Multinodular goiter occurs with a greater frequency in younger women due to their higher requirements of iodine. Often there are periods in which the gland has marginal functionality. To compensate, the pituitary gland elaborates additional TSH to maintain T3 and T4 levels at normal. The cyclic nature in which TSH levels rise and fall causes the thyroid gland to undergo periods of hypertrophy and hyperplasia followed by involution. Differences in growth and involution potential of the glandular tissue cause nodules to form. Over time, some nodules may begin to function without or with reduced amounts of TSH and thus may cause hyperthyroidism. Shown here is a serially sectioned thyroid gland. Within each section, one can see areas of normal thyroid tissue, which are brown to orange in color. Contrast the areas of normality with the areas of nodularity. These nodules are composed of follicular epithelium that has remained hypertrophic and hyperplastic throughout periods in which TSH levels have risen and fallen. Also seen in these sections are areas of gland that have undergone fibrosis and cystic change. The treatment for multinodular goiter includes iodine supplementation, which eliminates the cause of the problem, surgical ablation to correct for hyperfunctionality, radioablation, a procedure in which radioactive iodine administered concentrates in the gland and destroys tissue, and hormone replacement therapy, which is used if the gland must be removed or ablation therapy proves too extensive. Neoplasms of the thyroid often present as palpable nodules. Most nodules are benign and pose no immediate threat. However, 1% of all nodules are malignant and must be removed. Because of the natural planes of dissection, surgical removal of the thyroid gland or one of its lobes is a relatively simple procedure. However, once the area anatomy has been surgerized, the natural planes of dissection are replaced with scar tissue. Thus, surgical intervention in the same area for a second time necessitates a tedious and laborious dissection. Because of the anatomical position of the thyroid gland relative to the recurrent laryngeal nerve, the potential for accidentally severing the nerve is considerable during reintervention. Structures innervated by this nerve include the vocal cords. Should the right or left nerve be accidentally severed during a surgical procedure, the patient's voice will become hoarse due to unilateral vocal cord paralysis. Should both nerves be severed, the patient will be mute and will require a permanent tracheostomy to breathe. This is because without innervation, both vocal cords become flaccid and occlude the airway. As a consequence of the complications, surgical intervention to remove a nodule must proceed with the assumption that reintervention will not be possible. Surgical removal of a nodule usually proceeds as at least a lobectomy. Because this can result in hypothyroidism and require permanent hormone replacement, a nodule usually will only be removed if it is somehow life-threatening. Malignant neoplasms constitute such a threat. However, benign nodules do not. But how is a clinician to tell the difference? Consider the consequences. Removal of a benign nodule could result in iatrogenic hypothyroidism. Failure to remove a malignant neoplasm could result in cancer-related death. Several statistics and procedures may be considered to address this dilemma. With respect to statistics, solitary nodules, nodules occurring in younger patients, and nodules occurring in males are more likely to be neoplastic. Nodules which absorb more iodine relative to normal thyroid tissue, i.e., hot nodules, are more likely to be benign. 1 in 10 nodules which absorb less iodine relative to normal thyroid tissue, i.e., cold nodules, are known to be malignant. To assess whether a nodule is cold or hot, one must use an imaging technique called a scintillation scan. This is a procedure in which either a radioactive isotope of iodine or technetium-99 is administered. These compounds concentrate in the thyroid gland. The activity of the thyroid tissue is then topographically mapped using a scintillation camera. A normal thyroid scan is shown here. Areas which are darker indicate higher activity, and thus are areas in which iodine is being concentrated. Areas which are lighter are relatively lacking in activity and therefore are not concentrating iodine. One can see the right lobe of the thyroid here, the left lobe of the thyroid here, and the isthmus here. Note the uniform distribution of the iodine uptake. This is a scintillation scan of a normal thyroid gland. Shown here is a thyroid scintillation scan remarkable for a cold nodule, that is, a nodule absorbing less iodine relative to surrounding thyroid tissue. Note the area of reduced iodine uptake in the left lobe. This is the appearance of a cold nodule. The fact that the nodule is cold confers a 10% probability of malignancy. Upon histologic examination of tissue, the nodule proved only to be a benign adenoma. The resection of the nodule, which is in the form of a left lobectomy, is presented. Normal thyroid tissue comprising the lobe can be seen here, and the nodule can be seen here. The gross appearance is consistent with a benign lesion in that the nodule is well circumscribed. Remember, this is a rule of thumb, not a law of the universe. Superimposed is the pre-resection scintillation scan of the nodule. A more definitive preoperative diagnosis can be made by sampling the contents of the nodule using a procedure called fine needle aspiration, or FNA. With this procedure, a needle is inserted into the nodule and a sample of cells is removed for analysis. Final diagnosis, however, can only be made if and when the nodule is removed and studied by the pathologist. The 4 parathyroid glands of the body regulate blood calcium levels. An H&E stained section through one of the 4 glands is shown here. The gland consists of 2 types of parenchymal cells. The smaller of these cells, called chief cells, secrete parathyroid hormone, also known as PTH. PTH stimulates osteoclasts to mobilize calcium from bone, increases tubular resorption of calcium from the kidney, and augments GI absorption of calcium. PTH secretion by chief cells is primarily regulated by levels of ionized calcium in the blood, with declining levels of calcium enhancing production of the hormone. Once mobilized, PTH restores calcium levels to optimal. The larger cells, known as oxyphil cells, have an uncertain function. Hyperparathyroidism describes a condition in which PTH is elaborated in excess. 3 subtypes of hyperparathyroidism are recognized. Primary hyperparathyroidism occurs when 1 or more glands autonomously produce PTH in excess, causing serum-free calcium levels to increase beyond normal limits. Secondary hyperparathyroidism occurs when chronically depressed calcium levels secondarily cause PTH to be secreted in higher levels than normal. Tertiary hyperparathyroidism, a condition beyond the scope of this narrative, is associated with chronic renal failure and will not be discussed further. Causes of primary disease include adenomas and primary gland hyperplasia. Adenomas usually occur in only 1 of the 4 glands. As a consequence, the remaining 3 glands may be normal or reduced in size. The increased levels of calcium caused by the adenoma could force the remaining 3 glands to atrophy due to chronic inhibition. Shown is an H&E stained section through a normal parathyroid gland. In this section, one can see the parenchymal tissue of the gland here. Note that the parenchymal tissue is extensively infiltrated by adipose tissue. The proportion of adipose tissue naturally increases in the gland with age. Note also the extensive vascularity of the gland. These blood vessels effectively disseminate hormones elaborated by the gland systemically. Compare the appearance of normal parathyroid gland with that of a gland containing an autonomously functioning adenoma. The neoplastic adenoma is growing from within the center of the gland and is expanding outward. As the adenoma expands, it compresses normal surrounding tissue. The functional tissue that remains forms a rim around the growing adenoma. Other causes of primary hyperparathyroidism include primary gland hyperplasia, which may occur sporadically with uncertain etiology or may occur in association with certain endocrine syndromes. All four glands become variably enlarged when PTH-secreting chief cells proliferate, replacing glandular adipose tissue. This results in a glandular architecture characterized by densely populated eosinophilic hormonally active cells. Regardless of the etiology of primary hyperparathyroidism, elevated levels of PTH stimulate osteoclasts to mobilize calcium from bone, resulting in hypercalcemia. Resorption of calcium from the metaphysis of long bones is particularly prominent. As bone is resorbed, patients develop an osteoporosis-like condition in which both cortical and trabecular bone are diminished in mass. Compare normal trabecular bone to osteoporotic bone. First note the dimension and density of normal trabeculae seen in the scanning electron micrograph. Contrast normal bone to osteoporotic bone. Note the reduction in density and dimensions of the trabeculae. This is one manifestation of osteoporosis. Calcium is also mobilized from cortical bone. Compare the normal histology of cortical bone with that of osteoporotic bone. Note the impressive reduction in cortical bone thickness. Rapid and excessive bone resorption can result in osteitis fibrosa cystica, a condition in which hemorrhagic cysts form in the bone. The resulting hypercalcemia causes metastatic calcification to occur throughout the body. Organs affected include stomach, lungs, heart, blood vessels, and kidney. Calcification of the renal interstitium and tubules is referred to as nephrocalcinosis and may occur in association with nephrolithiasis, i.e. renal stones. Other symptoms include elevated levels of parathyroid hormone and hypophosphatemia. Hypophosphatemia occurs when free calcium combines with phosphates to create calcium phosphate salts, which may precipitate out of solution. One word of caution to be considered when evaluating patients with hypercalcemia. One must always include the possibility, however unlikely, of malignancy in his or her differential. This is because hypercalcemia is an exceptionally common paraneoplastic syndrome. Secondary hyperparathyroidism is associated with chronically depressed serum calcium levels. Under these conditions, the parathyroid glands must elaborate higher than normal levels of PTH to maintain serum calcium within normal range. As a result, all four glands become hyperplastic. The most common cause of secondary hyperparathyroidism is renal failure. When kidneys fail, they are unable to adequately excrete phosphate. As phosphate levels become elevated, calcium phosphate salts form, thereby depressing calcium concentrations in the plasma. Other common causes include a reduction in dietary calcium or dietary vitamin D. Remember that vitamin D regulates GI and renal absorption of calcium. Without vitamin D, calcium is lost from the GI and renal systems. Note that any disease resulting in steatorrhea may cause a vitamin D deficiency, since this vitamin is fat-soluble. Hypoparathyroidism, which presents with hypocalcemia and subnormal PTH levels, can be caused by surgical ablation of the glands or by idiopathic gland atrophy. Patients who are hypocalcemic may complain of muscle spasms or tingling sensations, especially around the mouth. A clinician must be particularly vigilant of these symptoms in patients who have undergone thyroidectomies. Because of their proximity to the thyroid gland, it is possible that the parathyroids can be accidentally removed or damaged during this procedure. Before studying disorders of the adrenal glands, a review of their architecture and function is warranted. The histology of a normal adrenal gland can be seen in this Eisenstein section. The adrenal gland consists of two components,
a cortex which elaborates steroid hormones, and a medulla which synthesizes catecholamines. The cortex in turn is composed of three layers. The zona glomerulosa synthesizes mineralocorticoids such as aldosterone. The zona fasciculata produces glucocorticoids such as cortisol. And finally, the zona reticularis elaborates androgens. The zona fasciculata and reticularis require the trophic hormone ACTH for function and maintenance. Without ACTH, both these layers atrophy and cease their production of hormones. The function and maintenance of the glomerulosa, in contrast, is primarily governed by the renin-angiotensin-aldosterone axis. Although a minimal concentration of ACTH is required for glomerulosa function, this hormone confers only a permissive effect on aldosterone production. Thus, changes in ACTH blood levels are generally not physiologically relevant to the function of this cortical layer. Production of cortisol is governed by ACTH elaborated by the pituitary gland. Varying physiologic and emotional states such as stress can enhance the production of ACTH. Under stress, the hypothalamus is stimulated to produce corticotropin releasing factor. This releasing factor is carried to the anterior pituitary gland via the portal system where it stimulates corticotrophs to produce ACTH. ACTH acts on the adrenal gland cortex to enhance the production of cortisol. As blood cortisol levels increase, both the hypothalamus and anterior pituitary gland are feedback inhibited, thereby preventing overproduction of the glucocorticoid. Cortisol also alters body physiology to better function under stressful conditions. This includes mobilizing energy reserves by enhancing gluconeogenesis, mobilizing proteins, and promoting lipolysis. This altered physiology, in theory, should help alleviate the stress, thereby reducing the requirements of cortisol, completing a negative feedback loop.
Hypercortisolism results in a spectrum of disease called Cushing's syndrome. One of the most common causes of hypercortisolism is iatrogenic in etiology. In this case, exogenous administration of steroids such as prednisone or methylprednisone is employed to treat such things as autoimmune diseases. These steroids serve to suppress the immune system and reduce the severity of autoimmune disease symptoms. Iatrogenic Cushing syndrome is one unfortunate side effect. In addition, these steroids inhibit production of ACTH by the anterior pituitary gland. Without this trophic hormone, the zona reticularis and fasciculata will atrophy bilaterally. Compare an H&E stained section of a normal gland with that of a gland that has atrophied due to exogenous administration of steroid. Note the thickness of the normal cortex in comparison to the medulla. Contrast these normal proportions with the proportions of an atrophic adrenal gland. Note the impressive reduction in cortical thickness. Because exogenous administration of steroid results in bilateral atrophy, adrenal glands must be allowed time to recover function prior to discontinuation of steroid use. For this reason, patients required to discontinue steroid are instructed to taper dosages over several weeks. Without this provision, sudden discontinuation of drug could precipitate an adrenal crisis due to hypocortisolism. An adrenal gland crisis is characterized by intractable vomiting, abdominal pain, hypotension, coma, and shock. Primary hypercortisolism occurs when the adrenal gland produces cortisol independent of ACTH levels. Neoplastic lesions such as adrenal adenomas can autonomously produce cortisol in excess, resulting in a Cushing's syndrome. Adenomas of the adrenal gland occur with a greater frequency than do symptoms, leading one to believe that many such adenomas are non-functional and thus do not elaborate hormone. One can see the general histologic architecture of an adenoma in this H&E stained section of the adrenal gland. Generally, adenomas present as well-circumscribed lesions which have a yellow cut surface. Secondary hypercortisolism occurs when ACTH is elaborated in excess. This can be the result of pituitary or hypothalamic disorders. The resulting spectrum of disease is referred to as Cushing's disease as opposed to Cushing's syndrome. The excessive ACTH produced causes the adrenal glands to become hyperplastic bilaterally. Nodular hyperplasia of the cortices is common. Compare the thickness of the normal cortex with the cortical thickness of a gland that has become hyperplastic due to excessive ACTH secretion. Generally, the adrenal cortex is hyperplastic and nodular bilaterally. Hypercortisolism results in the development of a Cushingoid body habitus. Centripetal obesity is one characteristic. Patients develop a quote-unquote moon face. Shown here is a woman who presented with hypercortisolism due to a cortisol-secreting adenoma. On the left, one can see her appearance before treatment. Notice the fat distribution confers a round quote-unquote moon-like contour to the face. On the right, one can see her appearance several weeks after the adrenal gland tumor was removed. Note the difference in facial contour. Within the context of hypercortisolism, fat is distributed abnormally. The posterior aspect of the neck is one such location in which fat is abnormally deposited. The abnormal deposition results in the formation of a posterior fat band or quote-unquote buffalo hump on the back of the neck. Other symptoms of hypercortisolism include hyperglycemia causing glucosauria and polydipsia, protein catabolism resulting in skin atrophy with stria formation, and muscle atrophy. Other symptoms include osteoporosis, steroid-induced immunodeficiencies, hirsutism, menstrual irregularities, and mental status changes. Patients with hypercortisolism are at the very least emotionally labile, i.e. they have wide mood swings. Once the symptoms of hypercortisolism have been established, the disease etiology must be identified. To do this, several facts must be considered. Various causes of hypercortisolism are shown here in diagrammatic form. Possible causes include pituitary Cushing syndrome, i.e. Cushing's disease, usually resulting from an ACTH-producing adenoma of the anterior pituitary gland. Paraneoplastic Cushing syndrome, in which a tumor, very commonly an oat cell malignancy of the lung, elaborates ACTH or an ACTH-like hormone. Primary hypercortisolism, i.e. adrenal Cushing syndrome, is usually caused by a cortisol-secreting adenoma or primary hyperplasia of the gland. And finally, iatrogenic Cushing syndrome, caused by administration of exogenous steroid. Hypercortisolism in which ACTH is elevated can be caused by only two possibilities: paraneoplasia or a pituitary adenoma. To differentiate between these remaining possibilities, one may use a dexamethasone suppression test. With this procedure, dexamethasone, a steroid, is administered to the patient. Corticotrophs in a pituitary adenoma, although less sensitive to feedback inhibition, can still be suppressed by higher levels of steroids. Malignancies, including oat cell tumors, elaborate ACTH without any feedback inhibitory machinery. Thus, in response to a dexamethasone suppression test, ACTH levels will decline in pituitary Cushing syndrome, but will remain elevated in paraneoplastic Cushing syndrome, allowing the clinician to differentiate between these two disease processes. Hypercortisolism in which ACTH production is suppressed can once again be caused by only two of these possibilities: adrenal Cushing syndrome or iatrogenic Cushing syndrome. A simple history of steroid use should be sufficient to differentiate between these two remaining possibilities. Hypoadrenalism is divided broadly into primary and secondary causes. Primary causes include Addison's disease, in which the adrenal cortex is destroyed by an autoimmune adrenalitis. Symptoms of adrenal gland insufficiency manifest when 90% of the cortical mass is destroyed. These symptoms include weakness, hypoglycemia, anorexia, nausea and vomiting, diarrhea, and of course weight loss.
Most of these symptoms result from hypocortisolism. In addition, patients may be hyperkalemic and hyponatremic if the zona glomerulosa is destroyed. As cortisol levels decline, the anterior pituitary gland elaborates greater quantities of ACTH in an attempt to maintain nominal cortisol levels. Thus, with primary adrenal insufficiency, ACTH levels will be above normal. Recall that ACTH is elaborated as a precursor which has melanocyte-stimulating properties. As a consequence, Caucasian patients with Addison's disease, such as President Kennedy, generally present with a well-tanned appearance. Secondary hypocortisolism occurs when the anterior pituitary gland fails to produce enough ACTH. The symptoms of secondary hypocortisolism are similar to those of primary disease, with one notable exception. ACTH and its precursor are at reduced levels. Thus, Caucasian patients with secondary hypocortisolism may be more pale than is otherwise normal. Question number 1. An 8-month-old infant is being evaluated for growth and mental retardation. Physical examination is remarkable for a small infant with dry, rough skin, a protuberant abdomen, periorbital edema, broad nose, and a large protuberant tongue. Which of the following is the most likely cause of the infant's symptoms? Answers include Graves' disease, cretinism, toxic multinodular goiter, toxic adenoma, and struma ovare. The description of the child is compatible with cretinism, a condition which arises as a result of hypothyroidism during childhood or fetal development. Cretinism is characterized by short stature, skeletal malformations, and coarse facial features. Graves' disease results in hyperthyroidism and can present with diffuse thyroid enlargement, exophthalmos, and pretibial myxedema. Toxic multinodular goiter results in hyperthyroidism and usually is a consequence of chronic iodine deficiency. Toxic adenoma could refer to a hyperfunctional thyroid adenoma or a TSH-secreting pituitary adenoma. Whichever the case, both result in hyperthyroidism. Struma ovare refers to an ectopic production of thyroid hormone from an ovarian teratoma, a type of ovarian neoplasm. Question number 2. A 65-year-old male presents with bone pain and is found to have hypocalcemia and increased parathyroid hormone levels. Surgical exploration of his neck is remarkable in that all 4 of his parathyroid glands are enlarged. Which of the following is the most likely cause of the gland enlargement? Answers include primary hyperplasia, parathyroid adenoma, chronic renal failure, parathyroid carcinoma, lung carcinoma. Blood values presented are compatible with secondary hyperparathyroidism. Consider the possibilities with respect to blood calcium levels, parathyroid hormone levels, and gland size. Primary hyperplasia results in a primary hyperparathyroidism in which blood chemistries would be remarkable for an increase in calcium and an increase in parathyroid hormone. All 4 glands would most likely be variably enlarged. Parathyroid adenomas could be hyperfunctional in that PTH levels could be elevated, causing calcium levels to increase. Most likely, the gland harboring the adenoma would be enlarged, while the remaining 3 glands could be reduced in size due to atrophy. Chronic renal failure results in hyperphosphatemia. Phosphates complex with calcium and can precipitate out of solution. Blood calcium levels would therefore decline. To compensate, parathyroid hormone levels would increase. Chronically depressed levels of calcium would cause all 4 glands to hypertrophy. Parathyroid cancer could present with the same spectrum of findings as parathyroid adenoma. Lung cancer could elaborate parathyroid hormone or parathyroid-like hormone as a paraneoplastic syndrome. This would increase calcium levels and cause all 4 glands to atrophy. All things considered, the best answer would be chronic renal failure. Question number 3. The most common endogenous etiologic factor in Cushing's syndrome is adrenal adenoma, bilateral adrenal hyperplasia, i.e. primary hyperplasia, adrenal carcinoma, ectopic adrenal tissue, hypercortisolism secondary to non-endocrine malignant tumors, i.e. a paraneoplastic syndrome. Here's one you just had to know. The answer is B, bilateral adrenal hyperplasia. There's very little rationale that one can employ to isolate the correct answer. In general, carcinomas and adenomas are rarer than hyperplasias. Question number 4. The testing profile of a patient on long-term exogenous glucocorticoid administration is most likely to be which of the following? The answers provided profile 4 blood chemistry variables: ACTH, aldosterone, potassium, and sodium. Plus symbols indicate levels above normal. Minus symbols indicate levels below normal. Begin with the first variable listed, ACTH. Administration of exogenous steroid will feedback inhibit the corticotrophs in the anterior pituitary gland. Thus, one would expect ACTH levels to be subnormal. This concept precludes A, B, and C as credible answers. The choice between D and E remains. Consider the next variable, aldosterone levels. Generally, beyond a permissive effect, the levels of ACTH do not influence aldosterone production. Remember that aldosterone production is mainly governed by the renin-angiotensinogen-aldosterone axis. Thus, one would expect aldosterone levels to remain within normal limits and not decline. Thus, answer E seems a more credible answer than D. An additional argument can be presented discrediting answer D. Should aldosterone levels decline, one would expect a resultant hyponatremia and hyperkalemia. Yet answer D lists potassium levels remaining within normal limits. This seems an unlikely consequence of reduced aldosterone secretion. Answer D contains a logical inconsistency. Thus, once again, answer E is the better answer. Question number 5. A 42-year-old man complains that he has had a change in shoe size from 9 to 10.5. He also states that his hands and jaw are now larger. This disorder is most likely mediated through the actions of excess prolactin, ACTH, somatomedin, antidiuretic hormone, or thyrotropin, also known as TSH. The symptoms described are compatible with acromegaly caused by an excess production of growth hormone. Although perplexing at first, this is not an answer. In the male, hyperprolactinemia may present simply with loss of libido. In the female, hyperprolactinemia may present with amenorrhea, galactorrhea, loss of libido, and infertility. None of these symptoms are compatible with this man's presentation. Excess ACTH would cause Cushingoid changes as well as hyperpigmentation. Again, symptoms not compatible with this man's presentation. Somatomedin is a compound synthesized in the liver under the influence of growth hormone. It is somatomedin that mediates the effects of growth hormone on end organ targets. Thus, C seems to be the most viable answer. Excess production of antidiuretic hormone would result in a dilutional hyponatremia, but would otherwise not be able to account for this man's changes in body habitus. Excess production of TSH results in a secondary hyperthyroidism, a condition associated with an enhanced metabolic rate. Clearly, the best answer is C, somatomedin, a small peptide which mediates the end organ effects of growth hormone. Question number 6. A 49-year-old man who smokes 2 packs of cigarettes per day presents with a lung mass detectable on chest radiograph and a weight gain. Lab tests are remarkable for hyponatremia with hyperosmolar urine. The patient probably has renal failure, pituitary failure, Conn syndrome, cardiac failure, inappropriate secretion of ADH. Hyponatremia is indicative of a low plasma osmolarity.
Despite this, the urine is hyperosmolar. These findings are inconsistent with normal physiologic function. That is, the kidneys are inappropriately resorbing water, resulting in a dilutional hyponatremia.
There are several answers listed which could account for this abnormality. The history of a lung mass is relevant since symptoms could be caused by a paraneoplastic syndrome. Renal failure could result in fluid retention and oliguria. However, the urine would most likely not be hyperosmolar, since viable kidney function is required to concentrate urine. Pituitary failure could include cessation in the production of antidiuretic hormone. This would cause the kidneys to lose fluid, resulting in hypernatremia.
Conn syndrome refers to primary hyperaldosteronism, which would present with hypertension, hypervolemia, hypernatremia, and hypokalemia. Cardiac failure could result in renal hypoperfusion, causing kidneys to retain fluids. This may be a viable answer. SIADH, or syndrome of inappropriate ADH secretion, however, seems a better answer. A lung primary could present with a paraneoplastic syndrome in which ADH is produced autonomously, causing fluid retention and hyponatremia. Thus, given the choice between answers D and E, answer E seems the better answer, since it is more compatible with this patient's presentation.
Question number 7. Graves' disease is associated with all of the following except tachycardia, anti-TSH receptor antibodies, localized myxedema, toxic nodular goiter, and exophthalmos. Graves' disease refers to a primary hyperthyroidism in which antibodies attach and stimulate TSH receptors. Toxic nodular goiter is the only symptom listed which is inconsistent with Graves' disease. Graves' disease almost always presents with a diffuse, not nodular, gland enlargement. Thus, the correct answer is D.